Thank you, Chairman, for your kind introduction. First of all, I'd like to thank the organizing committee of VIOS 2021 for the invitation to this wonderful meeting again. Today, I'll talk about advanced techniques in ultrasound-guided ablation for the difficult lesions. Liver ablation has been accepted as one of the curative treatment options, especially for the early-stage HCC in most HCC treatment guidelines because of its excellent outcomes and proven safety. However, we still suffer from technically difficult lesions, which can result in incomplete ablation as well as substantial morbidity. There are several advanced techniques to make the complex lesion simple and safe. Those include fusion imaging, contrast-enhanced ultrasound, and artificial fluid. I think the following two speakers will cover fusion and contrast-enhanced ultrasound, so today I will focus more on artificial fluid in my talk. I like to split my talk in the following four questions. First, what is the difficult lesion for ultrasound-guided ablation? Second, what is the key solutions for the difficult lesions? Third, when do I use fusion, contrast-enhanced ultrasound, or artificial fluid? Fourth, what is the real benefit and pitfalls of artificial fluid? What is the difficult lesion for ultrasound-guided ablation? Most difficult thing is to define what is the difficult lesion. I would define the difficulty of lesion as the confidence degree of potentials for complete and safe ablation. There are two major factors on difficulty. First, tumor conspicuity and guiding imaging modality. Second, any dangerous structures along the electrode path or abutted to the potential ablation zone. The total difficulty of lesion is very complex because each factor shows broad spectrum and both factors are intermingled with each other. It is actually not so simple how to accurately estimate the final difficulty after applying all the potential advanced techniques. So you need to understand the difficulty assessment is very subjective depending on the availability of those techniques and your experience on each technique. One tip is to use any kind of ablation feasibility map or technical feasibility scoring system to scale the degree of technical difficulty. It will be very helpful not only for the operator but also for the referred physician or the patient. I wonder if you agree with or not. This is the feasibility map for liver ablation with consensus of 4 doctors in our center. The green color indicates the best candidate for ablation with no technical problem in most cases. The difficulty of yellow-colored sites are higher than the green-colored sites. If you use advanced techniques, including fusion, CUS, or artificial ascites, the difficulty could be decreased. Actually, I proposed a feasibility scoring system for ultrasound-guided hepatic ablation in 2011. I selected 5 important factors for successful ablation: safe electrode path, any risky organ for thermal injury, tumor size, tumor conspicuity, and heat sink effect. Although this is still subjective, but it is useful for me for better selection and successful ablation, as well as better communication with referred physician and patient. What is the key solutions for the difficult lesions? First, I would say we should improve the lesion conspicuity, which can guarantee the accurate placement of applicator by all advanced techniques. Second, we should separate the dangerous organ from the potential ablation zone by means of artificial fluid. What is the key solution for the difficult lesion? Please don't ablate if you are not sure of conspicuity and safety. Ask help from alternative options such as TACE or RT or PBT. Technical difficulty of ultrasound-guided ablation doesn't matter to those alternative treatment. We always meet the patient referred to ablation in our outpatient clinic and perform planning ultrasound with or without contrast materials. In planning phase, we carefully assess the lesion conspicuity with fusion and/or contrast-enhanced ultrasound, safe electrode path, and technical feasibility of artificial fluid. I think you may have similar protocol to assess the feasibility of ultrasound-guided thermal ablation. Most common techniques for me in daily practice is fusion plus artificial ascites in about 40% cases. Precise planning is the half of successful ablation, especially for difficult lesion. After deciding you ablate, you have to precisely plan how to ablate, including patient position, respiration state, electrode path, device type and number, whether to use fusion, contrast-enhanced ultrasound, or artificial fluid, ablation parameters, potential event during the ablation, and potential plans on those events, etc. What is the real benefit of artificial fluid? I think there is no reason not to use artificial fluid if the lesion conspicuity is not so good or there is any potential risk of thermal injury to the adjacent risky structures. There are no proven evidence of significant hazard of artificial fluid in the literatures. Additional time and expense of artificial fluid cannot be the issue because we just need 3 to 5 more minutes with 1 pack of DW solution. There are various methods for assessing the perihepatic peritoneal space, from direct needle puncture into the peritoneal space to insertion of a needle or sheath into the perihepatic space. Personally, I prefer to use the sheath rather than needle. Let me show you how to make artificial ascites in our center. Here's a very tiny tumor, but it is barely seen on the planning ultrasound like this. This is how to make artificial ascites in our center. We are using the patient's respiration. After skin and peritoneum anesthesia, I use 18-gauge angiopuncture sheath needle to select the peritoneal space. After approaching to the liver capsule like this, I instruct the patient to breathe in for downward displacement of the liver. At that time, I puncture just the subcapsular portion of the liver. After remove the stylet, I instruct the patient to breathe out and hold her breath. Usually the tip of sheath is slipped back into the peritoneal space. You can see the guide wire at the perihepatic space. And I change it 5 French angio sheath with dilator over the guide wire. And you can see the rapid infusion of DW solution through the 5 French sheath. Angiography sheath and ascites. And also you can see the tiny lesion clearly. After 30 seconds later, we can see the index tumor more clearly and insert electrode accurately. And also we can separate the liver capsule from the diaphragm. An ablation for 6 minutes. You can see quite optimal and safe ablation. So immediate post-ablation CT, quite optimal and safe ablation. So artificial ascites is a simple and easy and cheap technique, just using less than 3 minutes. This slide shows how I use artificial fluid in liver ablation. I use artificial ascites for any subcapsular tumor aborted to diaphragm, colon, or stomach, or peritoneum, or any tumor with poor conspicuity in hepatic dome. For any tumor in segment 7 bare area, I use artificial pleural effusion rather than ascites. For any tumor aborted to gallbladder, duodenum, or any tumor with post-op adhesion, I use hydrodissection. In most subcapsular tumor, even conspicuous tumor, I use artificial ascites at least to minimize peritoneal thermal injury. I use artificial pleural effusion only for the tumor located in segment 7 bare area. I use hydrodissection for the peri-gallbladder or paraduodenal tumor or post-op adhesion site. Here is a good example for artificial pleural effusion. A tiny 7 mm tumor at segment 7 bare area. Usually, this area would not be separated by artificial ascites. So I made artificial pleural effusion to minimize the thermal injury to the diaphragm. After 6-minute ablation, you can see the optimal ablation without significant thermal injury to the diaphragm. Here is an example for hydrodissection for the post-op adhesion case. This patient underwent left lateral segmenectomy for HCC several years ago. As you can see, 6 mm tiny tumor just along the resection margin, and displaced colon was closely averted to the potential ablation zone. I made a hydrodissection using the spinal needle and then ablated for 6 minutes. You can see the quite optimal ablation encompassing the tiny tumor, and there is no thermal injury to the adjacent bowel loop. What is the benefit of artificial fluid? We can improve tumor conspicuity and targeting, and we can avoid complication while enabling larger ablation zone with optimal ablation margin. And also we can reduce pain, narcotic use, and hospital stays of the patient. Although there is no randomized control study, many clinical cohort studies to prove the benefit of artificial fluid in liver ablation have been published during the recent decade. This paper from Taiwan demonstrated RFA following artificial ascites or artificial pleural effusion for high-risk located HCC may improve the outcomes. Another recent paper from Korea reported artificial ascites infusion was the effective and safe way to reduce pain when performing RFA for subcapsular HCC. Finally, what is the pitfalls of artificial fluid? First, accurate insertion of electrode into the tumor in the liver floating on the infused ascites is sometimes difficult than expected. Second, perihepatic adhesion due to post-op or post-TACE or ablation sites is the well-known for technical failure of artificial ascites. In this case, we have to use hydrodissection using the spinal needle. In summary, difficult lesion can be successfully ablated if you can use advanced techniques including fusion, contrast-enhanced ultrasound, and artificial fluid. Artificial fluid techniques is very useful to guarantee accurate and safe ablation with time cost effectiveness, although there are several pitfalls. Finally, I like to emphasize the basic is more important to provide successful ablation. Of course, advanced technique is useful, but without the basic, it is sometimes meaningless. Basic include careful selection, precise planning, accurate placement, optimal ablation. So please always keep in mind basic beyond the novel. Thank you for your attention. One more, I'd like to invite all of you to the special conference on tumor ablation in coming October. ACTA, Asian Conference on Tumor Ablation 2021, will be held in Tokyo, Japan. I think most programs will be proceeded on online for foreign participants. Anyway, please join and learn the cutting-edge knowledge on image-guided tumor ablation. Thank you very much.